Good afternoon, and welcome to our congressional briefing and national webinar on the report Pain in the Nation, the Epidemics of Alcohol, Drug, and Suicide Deaths, hosted by Trust for America's Health, or TIFA for short. My name is Tim Hughes, the External Relations and Outreach Manager at TIFA. We would like to thank our speakers and audience for being with us today. Real-time captioning is provided today by AI Media. Next slide, please. For closed captions, click on More at the bottom right of your screen with the three dots. Next, click on Closed Captions. Next slide. ASL interpretation is also being provided today by Keystone Interpreting Solutions with Becky and Sage as our interpreters today. If you would like to use ASL interpretation, hover your cursor over to the interpretation button on the bottom of your Zoom screen. For today, because we are having some technical issues, please make sure you select the English to French translation, and that'll pull up your ASL interpreters. Next slide. We encourage you all to share your thoughts and questions about today's presentation by typing them into the Q&A box. We'll try to answer as many as we can as time permits. To open the Q&A box, click the Q&A icon at the bottom on your screen. From there, select Enter when you are ready to submit your question. Next slide. And now it is my pleasure to introduce the moderator of this event, Dr. Takesha Dwan Everett. Dr. Everett is TIFA's Executive Vice President. In this role, she works in partnership with TIFA's President and CEO to chart and implement the organization's strategic direction and priorities, provides counsel on current and emerging policy issues, and engages with key organizations, policymakers, and other partners to advance policy priorities to improve public health and promote equity. Welcome, Dr. Everett.
Thank you so much, Tim, and thank you to everyone for joining us today for this important discussion. I want to welcome you all to this conversation, and as mentioned, I'm Dr. Takesha Dwan Everett, Executive Vice President for Trust for America's Health. First, I'd like to thank everyone who has joined us today, but also for our esteemed panelists who are taking their time today to be a part of this event. We are honored to have all of you here. And just as a reminder, you should be able to access the ASL interpretation following the instructions that my colleague Tim provided, as well as information that's going to be included in the chat. Our agenda for today is on the slide that you're seeing right now. And after our presentations, we will have time for discussion and questions from the audience. So I hope that you will actively listen and be prepared with your questions. Before we go into our panel, I want to just take a few minutes to give a brief recap of our 2025 Pain in the Nation report. A copy of the full report, including state-specific information, is available at www.tfah.org, and that's T as in trust, F as in for, A as in America, and H as in health.org. And we will also include that link a link to that in the chat. We hope for this briefing that you will be able to leave with a better understanding of the comprehensive policies and programs that help address the underlying causes of the crises featured in our Pain in the Nation report, that will also help heal individuals and build more resilient communities. Next slide. In 2017, TIFA began the Pain in the Nation report series to bring attention to the alcohol, drug, and suicide crises in the United States, and to highlight effective interventions and policies needed to address such deaths. The 2025 report data shows that the combined rate of alcohol, drug, and suicide deaths was down nationally in 2023 for the second straight year, after decades of increasing numbers of deaths. In 2023, 47,938 Americans died from alcohol-induced causes. The overall age-adjusted alcohol-induced mortality rate decreased by 7% from 2022 to 2023, and this decrease built on a 6% reduction from the prior year and crossed nearly all demographic and geographic groups. But it's important to note that such death still disproportionately impacts some groups. Alcohol-induced death rates in 2023 were highest among American Indian and Alaska Native people, adults between the ages of 55 and 74, as well as adults aged 35 to 54 and males. The overall suicide mortality rate remained virtually identical from 2022 to 2023 at roughly 14 deaths per 100,000 people, respectively. And in 2023, 49,316 Americans died from suicide. Age-adjusted suicide rates in 2023 were highest among American Indian and Alaska Native people, males, and adults ages 75 and older. And despite recent progress, it's important to note that over 200,000 Americans died due to alcohol, drugs, and suicide in 2023. And that's twice the rate of such deaths 20 years ago. Ultimately, we need to do better in ensuring that all communities have the resources needed to prevent these tragic deaths. Next slide. Our 2025 report includes a special feature on the progress related to drug overdose deaths. After precipitous increases in the rate of drug overdose deaths in 2020 and 2021, the 2022 overall overdose mortality rate was virtually unchanged, and the 2023 mortality rate was down by 4%. In May of this year, CDC released provisional data for 2024 showing an unprecedented 27% decrease in drug overdose deaths as compared to 2023. The predicted decrease translates to an average of 81 lives saved daily. Next slide. Recent reductions in drug overdose deaths are encouraging, but not universal to all communities. White people experienced a statistically significant decrease in drug overdose deaths, but other racial and ethnic population groups had non-significant changes or increases. Drug overdose death rates in 2023 were highest among American Indian, Alaska Native people, adults between the ages of 35 to 54, and Black Americans and males. Our next slide is going to show the progress that we've made in the prevention of drug overdose deaths that is due in part to investments in public health, including translating data to action, increased access to mental health supports, crisis intervention services, and substance misuse and overdose prevention policies. I think we should be on our next slide. 80% of the CDC's domestic budget goes directly to states and other jurisdictions to support local prevention programs. And this is a really important point. To maintain the progress that we've seen as it relates to these crises, we need to ensure that that we reach all communities, that our programs and activities are able to reach and grow to all communities, and we need to multiply these programs, not reduce them. Proposed budget cuts across the Department of Health and Human Services, also known as HHS, will have a direct impact on prevention programs in local communities. Next slide. The recently announced restructuring of HHS includes cuts to public health funding, in addition to layoffs of the federal public workforce, all threaten our advancements that we've seen in the data. The fiscal year 2026 President's budget request for HHS proposes significant funding cuts and programmatic restructuring in alignment with the administration's announced restructuring of the agency. The restructuring would consolidate several HHS agencies, including some programs from the Substance Abuse and Mental Health Services Administration, known as SAMHSA, and CDC into a new administration for a Healthy America, colloquially called AHA. These proposals include reducing SAMHSA's budget by roughly $1 billion and consolidating several of the agency's key block grants into a new behavioral health innovation grant, and eliminating the CDC's National Center for Injury Prevention and Control, known as the Injury Center, shifting some of the Injury Center programs into AHA, and cutting funding for these programs by roughly $200 million. In a few minutes, you'll hear from our speakers who will provide additional insights and details on these actions and their current and potential impacts. But I want to shift for a second into some policy recommendations on how we can take some next steps. Next slide. The next step to ensure sustained progress by restoring and continuing the important strategies, policies, and programs that have been built upon over decades and underpin the recent improvements that we've seen and continuously look for areas of improvement is where we're going to shift the conversation to now. The recommendations for policymakers within the report represents TIFA's research on the programs, investments, and legislation that is needed to improve the nation's behavioral health outcomes. First, we must protect investments in prevention and conditions that promote health. This means that protecting investments in injury and violence prevention and restoring and maintaining the workforce dedicated to these efforts must be a priority. Additionally, supporting policies and programs that reduce adverse childhood experiences and the impact of trauma and that promote positive childhood experiences are very important, as well as expanding funding for comprehensive suicide prevention efforts. Second, we need to reduce overdose risk and access to lethal means of suicide. This means supporting overdose prevention programs such as the CDC's Overdose Data to Action program. Additionally, tracking emerging trends to inform local, state, and national strategies, as well as bolstering the continuum of crisis intervention services, including the 988 service and Crisis Lifeline. Lastly, we must transform the mental health and substance use prevention system. This translates to ensuring that the prevention, treatment, and recovery workforce is bolstered and increasing access to behavioral health services by reauthorizing provisions of the Support for Patients and Communities Act. Overall, we need to focus on the underlying drivers of substance misuse through early intervention and prevention policies. Current and proposed budget rescissions and cuts to prevention programs will diminish current progress and ultimately cost us many lives. Now, we've shared this overview of the report and the data and trends, as well as some initial policy recommendations. I'm really excited to transition us to our esteemed panel. I want to remind you that we'll have some questions at the end of this panel, and we want to make sure that you use and submit your questions through the Q&A box. You can use that and not the chat, and we'll make sure that we answer as many questions as we possibly can. I'm so pleased to welcome our panel and provide these brief introductions. Regina Bell is a distinguished scholar and director of the Center on Addiction Policy at the O'Neill Institute for National and Global Health Law at Georgetown University Law Center. She is also a member of the faculty at Georgetown University's Graduate School of Arts and Sciences, where she directs the Master of Science in Addiction Policy and Practice program, a program that she founded in 2021. She serves on the National Advisory Council on Drug Abuse at the National Institutes of Health. After we hear from Regina Bell, we'll then hear from Christina Mullins, who is the Deputy Cabinet Secretary for Mental Health and Substance Use Disorder at West Virginia Department of Human and I did that in the reverse, and Health and Human Resources. In her 25-year tenure in state government, she's worked to establish West Virginia's youth anti-tobacco campaign, collaborated with a multitude of partners to launch a surveillance system for neonatal abstinence syndrome, co-authored the 2016 West Virginia overdose fatality analysis, and offered testimony to the U.S. Congress regarding the opioid epidemic in January of 2020. We'll then hear from Sharon Gilmartin, who is the Executive Director of the Safe States Alliance, a national nonprofit organization dedicated to strengthening the practice of injury and violence prevention. With over 2 decades of experience in public health leadership, policy advocacy, and coalition building, Sharon guides the Alliance's strategic vision to support state and local efforts in preventing injury and violence and promoting community safety. I think you can all agree that we have a well-knowledgeable, well-accomplished, and well-esteemed panel to have this discussion today. And it's now my honor to welcome Regina LaBelle from Georgetown University.
Thanks very much, Dr. Everett, and thanks so much for having us here today to talk about, all these important issues. Next slide, please. And next slide. I have no conflicts of interest to disclose, but I think it's important to note that I served in the Biden and Obama administrations. I was acting director of the White House Office of National Drug Control Policy in 2021. And in the Obama administration, I served at the Office of National Drug Control Policy for the entirety of the administration. So I really come to this from that perspective, from the federal lens. And what I want to talk about today is I'm going to do a bit of a deeper dive into some of the data that Dr. Everett talked about. And also, I'm going to go over the structural changes that have been proposed and have happened, some of the data challenges, as well as the budgetary and personnel issues. This is a moving picture. And so even, some of it is changing, even though I did these slides last week. So I'll try to keep, I'll update it as I go along. Next slide, please. So as Dr. Everett said, it's interesting to note the overdose deaths. I mean, we're still not, in the next slide I'll show, we're at less than 100,000, but I still remember being in the Obama administration in 2010 when we were at about 20,000 overdose deaths. And that's before fentanyl. And it was still, at that point, it was driven mostly by prescription opioids. And we knew it was a nationally urgent issue, but it's taken us a long time to get to the problem we're in now, and it's going to take us a while to get out of it as well. You can see that overdose death rates have gone down west of the Mississippi. That's really where illicitly manufactured fentanyl showed up first, and a little bit slower of a slowdown west of the Mississippi, where fentanyl was later. But also, as was noted, American Indian and Alaskan Native populations have higher risk of overdose deaths. And we've done a little bit of data collection to see that overdose deaths also among Black Americans are not universally down. In many states, they're up, while white overdose deaths have gone down. Next slide, please. So as I mentioned, we're less than 100,000 deaths at about 82,000 as of, we have almost a year lag, about 10 months lag. Next slide, please. So I'm going to go over the structural changes first, and I will distinguish between what has been proposed and what has happened. So next slide. In the next slide, we'll see this was the federal budget that was sent, the president's budget that was sent to the Hill for 2026. Congress is considering this now. The end of the fiscal year is October 1. This is where the Administration for a Healthy America comes in. So basically, all of these agencies will be combined. The idea is to combine them all into the Administration for a Healthy America. Again, this is a proposed budget. We don't know at this time whether or not Congress will include this change in the budget. Next slide, please. I think it's also really important to note the changes of the reorg that is being proposed for the National Institutes of Health. And the ones that affect substance use the most are the three on the left. So there's a National Institute on Alcohol Abuse and Alcoholism, National Institute on Drug Abuse, and a National Institute of Mental Health. The idea that's being proposed is to combine all three of them. And I'll go over the impact of that on the fiscal health of these agencies in a bit. Next slide, please. The other thing that I think is really important is to note that the National Center on Health Statistics right now is in the Center for Disease Control and Prevention. They do all of the, they release the data on overdose deaths and mortality data, et cetera. It has been separated from politics. And that's kind of their, the whole point of this is that the data that they collect, the data that they release are clean data that are devoid of politics. My concern about this is they are proposing to move the National Center for Health Statistics to HHS's Office of Strategy, which would come directly under the secretary. So there's some concern about that. But again, that's been proposed. Congress has to decide. Next slide, please. Now I'm going to go over the budgetary and personnel changes. Next slide, please. So about $1 billion has been clawed back, just $1 billion. It's $11 billion in total, clawed back from the states. This is in litigation. We know that the National Institute on Drug Abuse grants have slowed, and there have been a number of National Institutes of Health grants that have been terminated. Again, much of terminated or slowed. Much of this, again, is in litigation. Next slide, please. So I was a Fed and I also worked at the state level. So I've been a public employee in my career for almost 20 years. And I have a great deal of respect for the work of public employees and their dedication to the mission. Unfortunately, we've lost about 20,000 HHS employees, either through early retirement or reductions in force. 10% of SAMHSA staff has been terminated, and then 2,400 have lost their jobs at CDC, but some of them are being either reinstated or they're opening these positions up because it was done really quickly and there wasn't a lot of thought done to who's going to do the work. One of the changes that is significant for data is that the entire staff that administers and oversees the National Survey on Drug Use and Health was terminated. Next slide, please. So I'm going to get into some of the proposed changes. So on the budget proposal that went to Congress, programs of regional and national significance, which are a number of grants that are other than the block grants, have been proposed for elimination. The Stop Back grant is specifically important for this conversation because that's the only specific grant for underage alcohol use prevention. And there are a number of other grants that have been around for a long time, first responder training for naloxone. Those are all being proposed for elimination by the administration. Next slide, please. I'm going to go over the Medicaid stuff. I know I'm short on time, but Medicaid cuts are really significant also. The cuts that are being proposed in the FY26 budget would affect, as was said, if you combine the 3 block grants, so State Opioid Response Grant, the SUPTRS block grant, and the Mental Health block grant, it combines them and then reduces them by about $500 million. The importance of at least the Substance Use Prevention Treatment Recovery Grant is that funds, if a person is uninsured and needs treatment, that pays for that. It also is the #1 funder for prevention services for substance use disorder for the states. So any reduction, first of all, those grants have not kept pace with inflation. That's important to note. And then secondly, any reduction in that accompanied by the Medicaid grants will have a serious impact on states' ability to address overdose deaths and just substance use generally. Next slide, please. So again, the idea is to combine these grants and that take the research grants. This would be about a 38.1% budget cut overall. Next slide, please. So, and then finally, I'll end with this. The Reconciliation Act, the One Big Beautiful Bill, next slide, please, included what you've probably heard about, a community engagement requirement. So it can be volunteer work or work requirement. It also includes a couple of exceptions for someone who is in treatment, and this is how it's defined. I have it on the slide. And also there's an exception for people who are medically frail. So that includes someone with a substance use disorder. Now, states have to begin administering this they're supposed to start next December. A rule is going to be introduced by HHS in June of next year, telling states how to interpret these exceptions to the medical the worker requirement. Now, no one is saying that people shouldn't work, people should work. It's just there's a lot of questions about how it will be implemented. How does it affect people, the reentry population, who we know have higher rates of unemployment, and also, importantly, very high rates of overdose. So next slide, please. So with that, I will turn it back, and I look forward to hearing any questions you may have. Thanks.
Thank you so much, Regina, for that wonderful presentation. We'll now next hear from Christina Mullins from West Virginia's Department of Health and Human Services. Christina, welcome to the virtual podium, and you can take the mic.
Thank you. Next slide, please. And let's go on to the next one. So one of the things to know about West Virginia is we have experienced the highest rate of overdose deaths in the nation. And our rate in 2021 was 90.9 per 100,000 people. In response to the epidemic about 10 years ago, we started monitoring a number of other systems that West Virginia invested in, and we wanted to monitor federal and state funds toward it and how they impacted evidence-based practices. So we did, I'm sorry, I have gotten turned around. EMS responses to suspected overdoses steadily increased until 2021. The number of infants diagnosed with neonatal abstinence syndrome continued to rise through 2020, and the number of children in foster care reached an all-time high in 2019. Next slide, please. So in response to the rising numbers, we laid out a plan to invest our federal dollars, our state dollars, and our settlement dollars towards evidence-based practices. And some of those efforts included establishing a cross-agency data system to evaluate emerging trends. This was supported by our Overdose to Action grant. We increased access to medications for opioid use disorder through early adoption of the Medicaid 1115 waiver. We implemented a hub and spoke model for prescribing and implemented requirements for state-funded treatment programs to offer MOUD. We also expanded access to residential treatment services, increasing our capacity from 197 beds to over 1,800. There's probably some evidence to suggest that we have more beds than perhaps are needed at this time, but we are continuing to monitor that and allow, if you will, nature to take its course there. Next slide, please. We also encourage integrated care and community mental health centers, free clinics, and federally qualified health centers. We directed ongoing investments toward integrated treatment programs for mothers and infants. We also increased naloxone distribution from 3,879 kits in 2019 to over 90,000 kits annually from 2021 to 2024. Next slide, please. We also established and expanded certified recovery housing, peer employment, transitional support services. We advanced stigma reduction through public awareness, community mural projects, and education programs for clinicians and media professionals. We increased investments in community-based prevention initiatives. And in 2023, Governor Morrissey, our former Attorney General, established the West Virginia First Foundation as a private nonprofit organization to manage and distribute opioid settlement funds. And in case you didn't know, West Virginia did its own lawsuits. So we have we're approaching about $1 billion or a little plus or minus that will be able to be invested in addressing substance use disorder into the future. Next slide, please. Before I talk about these results, it's more to me than just naloxone distribution. I get asked that question a lot. Why we've been able to experience such good results? Is it just because we've put out 90,000 dose or kits of naloxone over the last 3 years? And yes, it may be a part of that. I hope so. And yes, it may also be in part a return to our baseline where we were before the pandemic. But I also believe these results reflect the maturity of the investments that we made in evidence-based programming earlier, 10 years ago, where we were starting those investments. So what we're starting to see now, remember at the beginning of my presentation, I talked about the different sectors that were impacted by the substance use disorder epidemic. So now we're seeing overdose deaths fall below pre-pandemic levels, but with a recent decline of 41.6%. The number of children removed due to caregiver substance use disorder decreased by 38.7% from 2017 to 2024. And EMS responses to suspected overdoses declined by 39.7% between 2021 and 2024. And infants diagnosed with neonatal abstinence syndrome dropped by 44.2% from 2020 to 2023. So we're seeing some corresponding decreases across our different sectors, which I think is really important to acknowledge, because you can begin to see that it goes beyond just naloxone distribution and supports the fact that treatment does work when individuals engage in treatment. Next slide, please. But West Virginia isn't finished. We can't afford a victory lap. It's likely we still lead the nation in the number of overdose deaths. So we plan to continue our partnership with Governor Morrisey and the West Virginia First Foundation to build on the successful efforts that have already been started. We want to strengthen the continuum of care to support treatment success, including abstinence from substance use, workforce participation, and stable housing. We want to use the data to identify effective programs and eliminate those that are not delivering results. We really have to be able to maximize the funds that we will have available to us, and that means investing wisely in programs that work. Next slide, please. Finally, I want to acknowledge the dedication and the really hard work of our partners. It's not been just the state government of West Virginia. It's been universities, colleges, community members, boots on the ground, first responders. So many different sectors have helped work on this to address this. But I also want to acknowledge the families that have been deeply impacted by this epidemic. They're the reason we do this, and it's really important work. So thank you so much.
Thank you so much, Christina, for sharing that amazing state example of how coordinated partnership that centers prevention can really have an impact on the crises that we're highlighting today in this webinar. Thank you so much. Finally, we will hear from Sharon Gilmartin from the Safe States Alliance. And as a reminder, we're going to pivot to Q&A and have questions to our panel right after this. So if you have questions that you would like to ask the panel, be sure that you're placing those in our Q&A feature, not the chat, but the Q&A feature, and we'll get to as many of those as we possibly can. All right, Sharon, if you don't mind, take it away.
All right, thank you. Good afternoon, everyone. Great to see so many of you here today. I am Sharon Gilmartin. Next slide. Executive Director of the Safe States Alliance. And for those of you who are unfamiliar with our work, Safe States is a national nonprofit and membership association dedicated to strengthening the injury and violence prevention. So within our focus. Next slide. If you're hearing anything from my fellow presenters and their presentations, I hope you're hearing both hope and concern. The progress we've made in preventing overdoses is very real. It's measurable, it's encouraging, but the reality is that it's also incredibly fragile when the systems that support this progress are under threat. Thanks to public health efforts, we have saved an estimated 81 lives a day from overdose, and that's truly extraordinary. But the fact remains that more than 80,000 people still died from overdose last year. Suicide claimed nearly 50,000 more lives, and alcohol-related deaths are climbing. So we're facing a moment of both hope and concern. And what we need to focus on is protecting the systems that are making progress possible. So I'm going to focus on one element of these systems today. And actually, we can go to the next slide. But I do want to be really clear, and I think this was underscored by my fellow presenters, that our progress is due to the sustained investments and coordination across multiple federal, state, and local partners who are all working tirelessly together to protect our communities. So one of the federal partners is the CDC's National Center for Injury Prevention and Control. We'll just call it the Injury Center because that is a mouthful. For over 30 years, the Injury Center has been the only federal entity solely dedicated to preventing injuries and violence. And one of its most essential programs is Overdose Data to Action, or OD2A, which you just heard Christina share a little bit about in West Virginia. So as background for that particular program, OD2A supports 49 states, 40 local jurisdictions, and Washington, D.C., with $280 million in funding to track and respond to overdose trends in real time. And what these funds allow communities to do is to really, in almost real time, collect, analyze, and apply data quickly to save lives. And so that can look like mapping overdose hotspots, conducting fatality reviews, improving prescribing practices, deploying peer recovery specialists. It's really the idea that OD2A enables coordinated, timely, and local action. But it is more than just a grant program. What I continue to reference it as the data backbone for the entire national overdose response. So we've heard a number of other federal agencies named here. Those federal agencies like SAMHSA, ONDCP, DOJ, and countless state and local systems, they all rely on that OD2A data to allocate resources, identify the emerging threats, and evaluate effectiveness. Because the data, they don't tell us just how many people are dying. They tell us who's most at risk, where help is most needed, when and how crises are emerging, and what can be done to intervene early. And what we've learned from years of public health response is that saving lives at this scale requires precision, speed, and coordination. And that can only happen when we have access to that real-time and trusted data and the expertise to interpret and act on it. So we really cannot have an effective overdose response without the Injury Center and without programs like OD2A. Next slide. So at Safe States, we've been really proud to lead advocacy for ongoing federal support for these investments and others through the Keep America Safe Coalition, which we launched in response to mounting threats to the CDC Injury Center funding beginning last year. The coalition itself brings together diverse partners from public health, from survivor advocates, community organizations. It's really inclusive because we all share that one common understanding that cutting federal funding for overdose and other important health outcomes, it's not just a policy decision, it's a public health decision that affects lives in a very real way. Unfortunately, today, our warning bells are ringing just as loud, if not louder than ever. And there are two key issues that we're elevating. Next slide. So the first is the current fiscal year's dollars. The FY25 funding is in limbo. And what's going on, typically when Congress passes a continuing resolution, agencies like CDC, like SAMHSA, they receive both their operating budgets and a lump sum disbursement to be able to fund programs in a continuous manner. This year, the process is looking really different, and you could go so far as to say it's broken. This year, the Office of Management and Budget, OMB, has not issued the operating budgets for FY25. So CDC and other agencies are receiving funding in 30-day increments without their full allocation in hand, which means they can't commit to full OD2A awards and countless others because they quite literally don't have the money in their accounts yet. This uncertainty has real consequences. We'll keep going with OD2A as our example. The grantees are facing delays in receiving their awards, and at this time are slated to receive only partial funding. Actually, yes, And there's also growing concerns that unspent funds could be clawed back at the end of the fiscal year. So this is an important advocacy opportunity because we all need to be reaching out to our representatives, whether that's our district offices, local governors and mayors, other elected officials, to press OMB to release the full FY25 funds to CDC and others immediately so that the funds can be obligated on time. So issue number one, OD2A and other CDC funding not guaranteed for FY25. Second, Dr. Everett referenced this earlier, the President's FY26 budget, there were a lot of changes proposed. One of those is the complete elimination of the CDC Injury Center altogether. They did suggest folding pieces of it into the new entity mentioned earlier, the Administration for Healthy America. That does not preserve OD2A or several other programs in their current form. We know the House and Senate still have to mark up their bills. I think Senate's markup is scheduled for Thursday. What happens next will determine whether this vital infrastructure survives. If these cuts are enacted, the consequences will be pretty swift and severe. We're going to have pretty quick loss of access to real-time data. We're going to see overdose prevention staff laid off or reassigned. And we're going to see that our state and local health departments who have been running these critical efforts will be forced to scale back or stop the coordinated work that they've built up over the last decade. And we'll lose the ability to track whether our prevention efforts are working at all. I think we can go to the last slide here. So what I would say, eliminating the injury center now at a time where we're finally seeing these necessary and impressive declines in overdose deaths would be short-sighted, dangerous, demoralizing to the public health workforce. And I think we can just wrap up with this. We know what works. We know what communities need. And we know that sustained and coordinated investments, not cuts, is the only path forward. So I hope all of us can be a part of the solution, stay informed, raise your voice, and remind people that these numbers represent lives and prevention is possible when we invest in it. Thank you so much. I'll hand it back to you.
Thank you so much, Sharon. And I want to just say now that this concludes our panel presentation, we're going to move to opening up for question and answers. And as a reminder, you can submit your questions in the Q&A panel, and you can type your questions and we can direct them to all of the panelists or to a specific panelist. And to help ensure that we are following your questions that are in that Q&A panel, I'm excited to be joined by my colleague, Lauren Battle, Government Relations Manager at TFAH, who will again help me in moderating this Q&A. I will turn it now to, well, actually, moderator's privilege. I'm going to ask the first question just to give Lauren a little bit of time to make sure we have some questions in there prompt for everybody. I think I'll start with Regina and ask you, Regina, a question about following on this last part about the FY26 budget request. And the fiscal year 2026 President's budget request proposes, as we've mentioned, shifting SAMHSA, several of the programs in the Injury Center and other agencies to this new AHA or AHA. And we've heard we've heard you talk about this a little bit. We heard Sharon mention a couple of these changes and the impact. How do you anticipate this potential shift to AHA will impact the substance misuse and overdose prevention efforts led by these agencies and centers, and ultimately the effect on interventions already that work within states like we've heard from Christina and other communities?
Right. Thanks for that question. So I know that, everybody agrees we all want a healthy America. The question is, what's the strategy? So I'm not sure at this time what the strategy is. My big concern is undermining an already fragile addiction infrastructure. And you heard from Christina how long it's taken to develop this. And as I said, I started, before that I was in Seattle and we had our own issues with substance use. But when I went into the administration, we had the I knew a guy approach to addiction treatment. There was not a whole lot of evidence a lot of times. It was just based on, I knew a guy who got better this way. And so the the rigor, a lot of the science and the research didn't really translate into policy. And we're seeing that. So I'm less concerned about what the structure is, but very, very concerned about who we're losing, who we've lost, and the funding losses that could really undermine this fragile addiction infrastructure we've been developing.
Thank you so much for that, Regina. It's really great way of really saying we're already in a fragile state and we don't need to cause any more harm to what's already fragile. We really need to build up so that we can maximize on these opportunities that have been successful and we know work. Lauren, I'm going to turn it to you to see what audience questions we may have now.
Thank you so much, Dr. Everett, and thank you so much to each of our panelists for being here. I'm going to start with the first question that we received from the audience. I think this is a question that either Professor LaBelle or any of our panelists could speak to, but one of our attendees has asked, does the drop in overdose deaths inversely correlate with the spread of naloxone availability to community members? Also something that a lot of you touched upon in your presentations already, but any points that you all would like to expand upon there?
I'm happy to take this. So I think certainly naloxone, the Substance Abuse and Mental Health Services Administration had a big effort a few years ago to have states develop naloxone saturation strategies. So basically, how do you get naloxone to where it's needed the most? And when we started this a lot with, it's a rural issue, we worked really closely with law enforcement to get them to carry naloxone. And now we've expanded it to get to communities where people are most at risk. So I think that definitely has something to do with it, the reduction in overdose deaths. But again, we can't stop just at reduction in overdose deaths. After people overdose, we need to help them and get them services. And I know that it's a clean metric, but it's not the only metric. So the answer to the question is yes, I think naloxone saturation to community members has had a lot to do with this, but it's not the only thing and it's not the only tool.
I would completely agree with that. And I think I would add, in addition to naloxone, the systems that are supporting substance use disorder and overdose more broadly have also been maturing and evolving. So, we talked about the data collection, but this is like real-time granular surveillance systems. There are now overdose alert systems, forensic toxicology improvements, which really enable that faster detection of spikes, of emerging threats. CDC has fabulous lab capacity that lets you identify when new drugs are coming into the drug supply, because that has a completely different type. Once you know to test for a certain drug, you have a fentanyl analog or a xylazine or something like that. Once you know it's in the drug supply, you respond, you test for it in your state, and you can treat that in a different way than you would treat, a heroin overdose. So those surveillance systems really have enabled us to be able to respond differently. I think there's also state and local capacity building where those funded health departments translate the data into action. I think Christina shared a beautiful example of what's happened in West Virginia, but we've seen this across the country. We've got Arizona redesigning dashboards. Illinois has spike response teams. Kentucky has drug checking expansion. And so that leads to targeted prevention support and harm reduction and overall improvements to overdose rates broadly. So it's naloxone in a broader context.
Thank you all so much for those responses. I'll move on to another question from the audience. I'll start with this one. How much of the reduction in overdose deaths is due to a reduction in opioid fatalities? I think this is definitely something that you all could speak to. Deputy Secretary Mullins, I think it might be particularly interesting to get some insight from you as to what this might have looked like in West Virginia specifically in regards to the impact of a reduction in opioid fatalities.
In West Virginia, we are seeing a significant reduction in overdose fatalities. It is, but it's a polysubstance event typically when we have an overdose death. But opioids tend to be the primary driver, and fentanyl being the most common driver of an actual fatality. So yes, opioids is still it still represents a significant portion of our deaths, but it is definitely declining and coming down, as is proportionally all of the categories. I think that that's also important to note. For us, there's so much reduction at 40+% that all categories are coming down, but opioids is definitely falling at the highest rate.
Thank you so much for that response. I'll move on to another question that we've received to each of our panelists. So whoever would like to speak to this first, based on your experience and big cuts in federal funds, where should local communities commit the most of their opioid abatement settlement funds for the greatest impact? Prevention, treatment, harm reduction, recovery, everything in between? Would be curious for your insight there.
I'll go first on that one. I would advocate for working with your state government agencies to understand the gaps. Prevention, I would say, is one of the categories that's in West Virginia, at least, I think I could say probably across the nation, is underfunded. So I'm a big advocate for prevention dollars, but as we see shifts in availability or how federal funds are used, I think that working closely with the state agencies to understand potential gaps and being able to be nimble in filling those gaps is going to be really important as we move forward.
Yeah, the only thing I'd add is that it shouldn't be the loudest voice at the table or the person who shows up at the meetings. It has to be look at the gaps, and every state's going to be different in that because every state is in a different aspect of the opioid overdose epidemic.
And my final addition here is that it's hard to really say focus on one specific thing, because the reality is that you need that full spectrum of services. You need the prevention all the way through treatment and recovery to really address this issue. So it sounds a little trite to say, but we do have to be able to allocate resources across that entire spectrum.
I'm actually going to pick up there on a question for you, Sharon. The point about being able to have programs and an approach that is across the spectrum and kind of across everything. Could you just highlight, because sometimes there's a little bit of confusion about the distinct roles that the injury center plays versus SAMHSA and how there's a distinction there. So could you just speak a little bit about that distinct and essential role between SAMHSA and the injury center, or I should say the injury center as opposed to what SAMHSA does, and how the efforts complement SAMHSA's treatment and recovery programs? I think it's a really great theme to dig a little deeper on.
I'm so glad you asked that, because this is something that we've heard from congressional representatives too, that why do we need both? It's duplicative when we could just have one agency focusing. So CDC's focus is on prevention. We're thinking about root causes of behavioral health challenges and really stopping problems before they start. That's where that data piece comes in, because it means using data to understand the trends, identify those risk and protective factors, and then implement the evidence-based strategies that will have the highest likelihood of reducing the mental health crises, the substance use or suicide in the first place. On the other hand, SAMHSA is primarily focused on treatment and recovery. So ensuring that once individuals are already struggling with substance use or mental health conditions, they have access to the services and supports they need to heal, to rebuild their lives. So SAMHSA is funding treatment programs, recovery services, crisis intervention, workforce development, all of the help that's there when people need it most. And the reality is that CDC and SAMHSA, they work hand in hand, and that multiplies the impact. We've got upstream prevention strategies, reducing the number of people entering crisis, and then SAMHSA's treatment and recovery programs providing a safety net for those already affected. And that, to the point earlier, that's really that full continuum of care from prevention all the way to support and recovery.
Amazing. Thank you so much for that. So we are, as always, we have rich conversations and they're so great, but we're limited on time. We're almost at the top of the hour. So I only have time for one more question. And I'm going to kind of blend this in. And try, I'm going to try to ask two people two different questions in the 5 or less minutes we have. So, or actually, I'm going to try to ask all of you one question and see if I can get in. I'm sneaking two. We'll see how we go. There have been a few questions in the Q&A saying, we love this information that has been shared today, that each of you have offered an amazing perspective, but what can some of the folks who are listening do about it? Or what kind of are some next steps there? So for any one of the three of you who have participated so far, we know that there are policy recommendations that are in our TFAH Pain in the Nation report that people could definitely read and do something with those. But what would you say in your capacity is it one or two things that people could do with this information you've shared today?
I'm happy to kick us off. The number one thing that you can do is reach out to your elected officials. And even if you serve in governmental public health, we know that people feel like there are limitations on their ability to speak up. You are a citizen of this country and you have every right to share the impacts in your communities. You also have the right to share the work that you do and concerns that you might have. I will put in the chat, we have a link on the Keep America Safe website that can connect you with your elected officials. We also have one on the Safe States website, so you don't have to go hunting and pecking for, what the email addresses are, but speak up. And they want to hear individual stories. They don't want to hear a talking head like me saying, here's the national impact. They want to hear about your community. They want to hear about your personal experience. It doesn't have to be fancy and polished. But the more that they hear from you, the more that they understand that it is a concern of their constituents.
I would echo that, and in that we need to share our stories, we need to share our successes, we need to share the impact that we're having in communities. And I would argue it goes beyond just sharing with our policymakers too. It's our community members so that they understand the work that we're trying to do and why it's important, so that they become part of that larger group that understands why we're doing what we do and reducing the stigma around the work as well.
Yeah, I think there's been some compassion fatigue over the years. We've been dealing with this issue for a while, and I think some people are like, well, nothing makes a difference. Well, things do make a difference, and we have come a long way. So as Christina said, share those success stories, but put a face on everything. How does this affect people? If you're an organization, you can collect stories. Some organizations are doing that. Talk to your elected officials and make sure they know how this affects your community at a basic level, so that they understand the decisions they make will have real life impacts on people in need. Thanks.
Well, I definitely can't sneak in another question. So what I will sneak in is my thanks. I want to thank Professor LaBelle, Deputy Secretary Mullins, and Ms. Gilmartin for joining us today. Also, a huge thank you to AI Media Caption Service and our behind the scenes staff, who is not at all behind the scenes, but are completely in the front of everything we do at TFAH. To each of you who have participated today, I just want to clearly say that this is an important issue that is so detrimental and instrumental to our nation's health that we have to pay attention to and address with our policymakers to reverse the crises that we've heard about today. A recording along with our slides and additional resources will be available on www.tfah.org in the coming days. And we'll do as best as we can to answer any unanswered questions that we had in the chat. Thank you so much for joining us, and I hope you have a wonderful rest of your week.
Thank you.